everybody. I'm here with Dr. Janie Grumley from St. John's Cancer Institute in Santa Monica, California. It's great to be with you.
Thank you for having me.
You're a very first person.
Yeah.
So are you feeling the pressure?
A little bit.
No. I think you're fine. I've heard this analogy that as a surgeon, you're like a quarterback, right? Do you agree with that?
I think with breast surgery, it is kind of that way, just because we tend to be the first person that patients come and see first, because we have that initial conversation about what should we do. They're panicked, they come in, they're like, oh my gosh, what do we do? And we tend to be that first person that they interact with, and then we kind of disperse it to the team. And so it's a really multidisciplinary team approach to all of our cancer patients.
Yeah, you have to, so you're the leader, but you have to come up with like literally a game plan.
Yeah.
Right?
Yeah.
For that particular individual.
Right.
Does some people, when they come in, just project like to the worst thing that could happen?
Absolutely.
Yeah.
All the time.
How do you deal with that?
Well, I think first of all is that, they want to be heard. So I always give them a chance to kind of talk about what their fears are, because they do jump to the conclusion that, oh my gosh, I'm dying.
Yeah.
But most of the time they are not, because we do screening, right? The reason we do screening is so we can find things really early. So it is not a life-threatening disease, and you have time to make decisions. And it's so important in that initial conversation to really educate them, because there's a lot of misconceptions out there, right?
Right.
So we take a lot of time sitting down with them and actually talking through what they actually have, because they think stage 0 is the same thing as stage 4.
Right.
Right? So we spend so much time actually
Educating.
explaining and educating so that they understand, oh, I can take a breath. This isn't the end of the world. Okay, I can see this is how you guys make decisions. This is what you found, and this is why I did screening, and I have so many options available to me, and it's not going to be this life-threatening thing.
You said there are a lot of misconceptions. What's
Yes.
the biggest misconception about radiation?
Well, I think it's easy to have that misconception that radiation is bad, because you've got all those big giant signs that says stay out, don't do this, right?
Right.
We think of it as something that is dangerous. And then now you get a cancer and we tell them now we're going to radiate you, which
Right.
for most people are thinking, wow, I don't want to do that. And it's true. You don't want to do it if you don't need it. And that is the key. If you have a bad cancer, we want to use that tool because it works. But if you don't have a bad cancer and your cancer is not going to respond to it, why are we using that tool? So it has to be very selective.
How does Decision RT help you from not overtreating patients with DCIS?
Yeah, so I mean, in the past, we've just kind of used general guidelines, right? How big it is and the estrogen receptor, your age, a lot of these things that are kind of helpful, but not definitive. And what's nice about the Decision RT is, as a physician, I want information.
Right.
I want information about this cancer, not somebody else's cancer. I want information about this cancer that can help me make that decision, or help the patient make the decision about what's worth it or not, right? And I love Decision RT because you get to take the tissue, you get to send it, you get some genetic information about it. It tells us how it wants to behave. And then you can sit down with the patient and say, okay, you're going to get a 5% benefit, or you're going to get a 2% benefit, or you're going to get no benefit, or it's 20%. And that helps them make a decision. It helps me guide them when it comes to talking about what's needed versus what's not, because everything in medicine, there's a side effect, right? It's not a one, everything is just good. There are side effects to everything we do, even surgery. And so we have to talk about what's your benefit and what's your risk. And so once we can sit down with a definitive answer to that for their cancer, not everybody else's cancer.
Right. Like
And
you
it
started
helps,
to say,
yeah.
It's not one size fits all.
It's not
yeah,
one size
I heard
fits
that
all.
phrase like coming into your mind, which
Yeah.
is perfect.
Right. Cancers are individual cells that are yours. So your cancer is very different from the next person, right? But we do put it in all this one giant wastebasket and say, oh, you have breast cancer. But people don't understand that just because somebody else had something happen to them doesn't mean that's going to happen to them.
In terms of a radiation oncologist, and some would obviously welcome a test like this, but isn't there a certain percentage that push back against the technology?
Yeah.
For those who really might not understand the logic, right? Like, don't you want to know definitively, or as definitively as possible, why do some radiation oncologists reject this type of testing?
I think part of it is the fact that we have a lot of data that says radiation works, right? A lot of data, long-term data. The problem with, adopting something new is that breast cancer patients tend to do well. So they want to see 20, 30, 40 years of data. But the problem is we're waiting a long time to get on board with something that makes sense.
Right.
Right? And we're not saying just based on this information, we're going to make decisions on treatment. It's just another piece of information that helps guide us and makes a lot more sense for patients when they're trying to understand, because they're not physicians.
Right.
It's hard for them to understand, do I need it, do I not need it? And having this test really helps guide them and make them feel comfortable.
I think it's so easy. Like, I remember walking into my radiation oncologist. She basically put it in front of me, and she's like, here it is.
Yeah.
And it, it was in black and white.
Yeah.
I mean, and I want to say, like, it was a no-brainer, really, at that point. I mean, I think once you can see it and understand, like, this is me, this is what it says, then making that decision is pretty seamless. And I think you feel a lot of confidence when you make that decision.
Right.
So can you give me an example of maybe a patient or two where really Decision RT has made a big difference?
I think there's lots of examples of that.
Okay.
So especially in your 40 to 50-year-old women, right? Because we think, oh, that's really young. And you've got DCIS already at that age. And so a lot of people have that fear of cancer, and so they kind of jump off the deep end. So some women will want a bilateral mastectomy because they're afraid of radiation, or they'll say, well, I'm young, so this must be really bad cancer. But that's not necessarily the case, because we're so much better at screening.
Right.
Right? So now we're finding things earlier, but that doesn't mean it's bad cancer. And then they also are the ones that have to live longer with the consequences of what we do to them. Right? So again,
I didn't even think about it that way. You're right, because then on the back end, you've got decades and decades of life.
Decades of life.
Right.
And DCIS is not a life-threatening disease, right? We found it early so we can prevent something bad from happening. So if you say, okay, well, I don't want radiation and I just want a mastectomy, now you're living your whole life with reconstruction, the complications of that, having an implant, having to have that taken out, exchanges, all of that stuff comes into play for a much longer period of time. Whereas if we do the test and you don't need radiation, you don't need to have radiation, and it's a great option. Then you don't have the effects of radiation. We don't have to worry about the small risk of angiosarcoma down the road. Like, all of those things come into play. So helping us make that better decision is really helpful. But if it says you do need this radiation, and we know up front that this is a choice, this is something that we want to do, then we can make those adjustments based on that information. Instead of saying, I don't know, I think we might need it, I think it'll be good for you, right? It's that uncertainty that I don't love. And we haven't had any tools up until now that helps us give definitive answers.
I think what's really interesting about what you're saying is this test has implications for radiation as treatment, but also beyond. When you're thinking about surgery, or thinking about something like a mastectomy, when your mind goes there, what this test really allows you to do is kind of approach your treatment in a more of a logical and knowledgeable manner. Is that
and also tailored to that person. Right? And that's the key. It's not, oh, we've got these large studies that everybody's involved, included, and this is what we see. This is your recurrence rate. We're talking about your disease and your cancer cells and what's the risk of recurrence in that. And it makes us, be able to be more confident when we give you recommendations about what we think you should do, right?
Right.
And so it's just another tool that really helps us.
Okay, so in conclusion, is there one word that you would use to describe the impact of Decision RT? Give me a word.
Life-changing. It really does. It changes a lot of people's perspectives on what they think they need and what their risk is. I mean, even if you come back with a low risk score, then they don't feel like they have that cancer hanging over them, because they know whatever it was low risk. Or if it is higher risk, then we've taken the measures to actually take care of it, right? So it gives them that kind of like, oh, I can live again because I have more answers.
Yeah, you could just exhale.
Yeah.
And
I'm sure you felt that way, right?
And just understand, like, I have a plan.
Right.
I'm really relieved I don't need radiation, and I can kind of go back to work and move on with my life and not have that, like, post-surgery piece that now I have to deal with.
Right.
You know,
have it hang over you the whole time.
That's right.
Yeah.
That's right.
Yeah.
Okay. Well, you are a pretty cool hockey mom, I gotta say.
Thank you.
Hockey mom, like amazing surgeon. And
Thank you.
it was a pleasure meeting you.
So nice to talk to you.
Thank you.